And we're going to discuss why the movement system is, in fact, the identity of physical therapy, explain the kinesiopathologic model, and what are some of the key components that make up this theoretic construct, and define how the kinesiopathologic model is related to a lot of these basic shoulder movement impairments that we see in the clinic. Now, please note that the 5 foundation webinars, there are 5 sessions to cover the entire kinesiopathologic model. So really considering that many of these issues for our patients are chronic. And then how do we apply the kinesiopathologic model into some of these shoulder girdle pain conditions? The definition is that it's a system of physiological organ systems that interact to produce movement of the body and its parts. The identity of physical therapy and the vision have been updated in 2013 by the American Physical Therapy Association. But all of you are seeing orthopedic cases, which is great because I think the framework of the kinesiopathologic model is so user-friendly for the orthopedic setting. The APTA white paper that was published in 2015, which is titled Physical Therapist Practice and the Movement System. And for some people, their movement goals might be that I just want to be able to get on my bike so that I can get to my work, to do the commute. Well, the goal of physical therapy is to really help people either regain, improve, and optimize movement. And as I've painted in the slides before, people have different goals or different levels of movement that they're trying to achieve to really improve their quality of life. So orthopedic surgeons, many of them, they might be specialists in hand, or they just see spine patients, or they mostly do hip surgeries, and etc. So I actually Googled physical therapy techniques, and it took like 0.33 seconds to come up with all of these. Well, 1, it's dangerous, and 2, it takes a professional with a certain set of knowledge to understand someone's heart condition or someone's metabolic condition to identify exactly what medicine that is going to help that individual. But we know and we can appreciate that the wrong exercise or the wrong instructions can make the patient's symptoms worse. And I think this is where a lot of the information overload is just like, oh, like I don't remember much of the details by the end of the 2-day course. So many people did not get a chance to learn the concept of relative stiffness and relative flexibility, which while they were a student, which is a shame. So today I'm going to show you the overall how non-optimal movements and non-optimal alignments can be causing symptoms in our patients with musculoskeletal pain problems. Appreciating that our body just wants to use what works best, regardless of whether that is a correct pattern or not so optimal pattern. And this mindset shift of let's really change the way that people are moving in order to decrease their pain rather than just jumping right into the pain. We have a lot of knowledge. This slide, I just want to paint the picture for the fact that we have some evidence and that many of the musculoskeletal conditions are chronic. They took 123 individuals from the community who self-reportedly said, I have pain in just the one shoulder. But what they did was they took MRI imaging of both shoulders and found out that, yes, both shoulders have abnormal MRI findings. Just the frequency of full thickness tears of the rotator cuff and the glenohumeral osteoarthritis were a little bit higher by maybe about 10% in the symptomatic shoulder compared to the surgeon's findings. I think we have to be a little bit careful that correlate with the patient's symptoms report and how they're moving, and really the functional loss could be a better indicator for coming up with the best treatment plan. I guess someone with a cervical spine extension syndrome with an accessory hypermobility at C6-7 while getting hurt at C6-7 after a whiplash, most likely, the arm elevation, starting around 20 degrees, going all the way up to about 150 degrees of arm elevation. And look at the shortest distance is actually between 24 degrees to about 64 degrees of arm elevation. So again, early on in the arm elevation is when subacromial impingement is happening. And look at let's appreciate that 100% of the subjects, when they raise their arm up overhead, the supraspinatus tendon is actually contacting the glenoid, and that would be considered internal impingement. Here's another evidence that musculoskeletal problems are chronic, that in fact they're happening long before symptoms start to come up. This is a study done in Australia, and that people over the age of 60 years or older, about a third of them already have shoulder osteoarthritis. And the incidence of shoulder pain range from 7.7 to 62 per 1,000 persons. So if you are a successful tennis player and can afford to have your own physio, then in the background you'd be doing all these preventative work, but sometimes they do have to just treat the symptoms. So it's kind of it's a lot to take in, but today I'm going to show you that changing the movement in fact can reduce the symptom. And the reason why we have so many tests is that because no one test is going to determine the movement system syndrome. So there's like, my documentation is not just like numbers, but there's lots of like qualitative comments written on the side, mostly just to help me. But for us, I need to kind of make notes of the quality so I can digest really why they have this pain. It didn't improve his scapular external rotation. That's the big issue with the wall slide, is if someone tends to be in too much scapular internal rotation because they're trying to reach for the wall, it doesn't help to correct that. I would hate for the humerus to keep going once the scapula stops moving, but he was also getting compensatory motion from the lumbar spine. Like, look, like you can change how you position your shoulder to get out of the pain. You can be in charge of your own pain. So scapular external rotators, posterior tilters, and then like performance of subscapularis to prevent that humeral head from going hello, like at the front door. And I think in the clinical setting, how do we differentiate what's truly short or something is just stiff, is that with repetitions, whether passively or actively, if you do enough repetitions and none of the range of motion changes. This is the same patient. I'm trying to explain to her why that previous shoulder medial rotation exercise is important, because when she's hitting her serve, she has to rapidly go from lateral to extend and then immediately rotate. But this, I think this one was more of a cervical spine issue. The levator scapula being put on stretch too much as well. There are so many centenarians, so many older folks living, therefore many chronic issues. But chronic issues aren't just for older population. We see younger people who do these very intensive training in their sports. You don't have to just jump into decreasing the pain first, that you can change how people are holding themselves up. This whole APTA vision and the identity that we should be lifespan practitioners, not just like seeing patients for once a week for 6 visits and that's it. And really what a lot of the PTs did back then was there were things that they were supposed to follow written on the prescription. And I know many of your our past course participants have said, attending the movement system syndromes courses really changed my clinical practice. If you found this foundation webinar useful, please consider attending the Shoulder Movement System Syndromes, which is a virtual course, 2 days, June 8th and June 9th.